Thank you so much, and thank you to Dr. Gutierrez and the whole organizing committee. It's been a delight to listen to you all and see all the excellent progress that's been going on in telemedicine. It's really exciting to see. So hopefully this will be a practical session. We've talked a lot about logistics and components. Hopefully now we can talk about actually the components of the exam, how we do it. And at Mayo here, we did some telemedicine, usually for our rural settings, but COVID changed everything and really had us doing a lot more. And for me, I do, as was mentioned, sports medicine and musculoskeletal medicine. How do we get the best information from our patients when we perform a telemedicine musculoskeletal exam? So that's what we sought to find out. So again, as many have said, in telemedicine initially, we used it mostly for remote settings. We grew tons and tons after COVID-19. But we're finding now that we're using telemedicine more that it is very safe. Use of PPE was mentioned. It's time and cost efficient. It's convenient. And again, it's here to stay. So people are looking at how we're going to use this in the future, also for follow-up visits and for actually incorporation of care into our practices. Musculoskeletal complaints are the #1 thing that people see a doctor for in the United States. Over the respiratory illness, common cold, everything, musculoskeletal, everybody has some kind of either neck pain or shoulder pain or knee pain or hip pain or whatever. So it's very important, I think, to have a framework for musculoskeletal evaluation for all our providers. And a lot of our primary care providers, not just our physiatric colleagues, but our primary care providers are our first line, our front line in this area. And I started getting a lot of calls. People ask me, "How do I do this? How do I do this over the video?" So we developed a set of guidelines, and they're both written and visual to enhance information. We chose the major joints, so we chose shoulder, hip, knee, ankle, and then the spine, the cervical and the lumbar spine. And this publication is now online. If you go on Mayo Clinic Proceedings, it's a general website, and just search for the telemedicine musculoskeletal examination, you will get it. So there's actually a 23-page document, and so it's both for the practitioner, to aid the practitioner, and also we have things for the patient as well, because we found when we're doing these exams, the patients were not prepared to do the exams. The dog would be on their lap, or the room would be dark, or kids would be running around in the room. We couldn't see them. So there needs to be an appropriate background as well. So we designed videos to assist both the performer of the musculoskeletal virtual exam and also the patient having the exam. So this is free. If you just search for this on Mayo Clinic Proceedings site, you will get it. There are associated pictures and videos. So we wanted to concentrate on the major joints because that's what most people see, including our primary care colleagues. We wanted to have visual aids as well because it's hard to describe these things in text sometimes. So we wanted to have videos as well as pictorial aids. We based our exam on validated physical exam maneuvers that we all perform in face-to-face encounters. But we tried to modify these so that the patient could self-perform these maneuvers. And that was the trick. So a lot of what we're developing here is not validated because the patient is performing it, but they're all based on validated examination techniques that we use now. A couple of general considerations we point out that you want to look at the video image of the patient, but also you want to look at the camera because that's like you're looking the patient in the eyes. Sometimes if we're always looking down at the screen, the patient doesn't feel the connection with us. At times we may need to look away to take notes, and we want the patient to know that we're not ignoring them. And there may also be an audio lag. It may not correspond exactly to our video. So you want to give the patient some time after they stop talking before we speak. I think if we can get a uniform pattern of doing the musculoskeletal physical exam, as in any physical exam, a virtual physical musculoskeletal exam, that's always the best. So it makes us include what we should and not forget what we can. Just to make it simple, we ask the patient to use one finger to point to the area of pain and to delineate where the pain is and radiating. And also, we have the ability to demonstrate the physical exam maneuver to the patient. So we can show them how to do it so that then they can do it. And we've done this with our videos also. We've tried to incorporate the patient themselves doing these exam maneuvers. Just a couple of general considerations. Again, we want adequate room. We want the patient to be able to have full range of motion about their joints in all planes. We want to watch them walk. We want to watch them perform sit-to-stand transfers and movement patterns. We want the room to be free of distractions, uncluttered background, good lighting. We request that another person be controlling the camera, because trying to have the patient control the camera and do the maneuvers and get the right vision is oftentimes very difficult. So we want an additional person if possible. And if there's children that we're evaluating, we want toys that the child can manipulate and play with and hold. We want to utilize those. So we made an introductory video, and this is just for people in general for the musculoskeletal exam. So I'll just play this for you. This is for the patient to see, and it's kind of just, we tried to make it a little fun. It's for mature audiences only, as you'll see, but well, we tried to give all these points in a manner that will be hopefully fun to convey to the patient. So I'm going to play this for you. Laskowski, and I'm a physician in physical medicine and rehabilitation and sports medicine at Mayo Clinic, Rochester. I'd like to share just a few thoughts on your upcoming telehealth examination. Video examinations can give us a lot of information. They're not a substitute for your face-to-face exam, but we can still gain a lot of information to hopefully help you out and give you some suggestions that help you deal with your condition. I'll give you some tips on how to set yourself up for a successful telehealth examination. First of all, you want enough space. The doctor may ask you to walk to and from the camera, so you want enough space that you can be walking forward and backwards. And the camera can catch this. It's nice if you can have somebody else holding the camera. It's always easier. So if someone else is available to help you, that would always be recommended, and I think it would enable you to do more movements and feel less impeded by anything. So somebody else to hold the camera is a good thing. Enough space is a good thing. A room free of distractions. We love your pets and everything else, but it's kind of distracting if they're in the field of view. So kind of keeping the room clear of distractions and as little possible in the room so we can see well, that's a good thing. Proper lighting in the room is also good. It helps us to see things very well. And your doctor, when you see them in the video, they'll probably be dressed like this, and they'll ask you some questions. They'll interview you, but this is an examination. So your doctor will be dressed like this, but we want you to be able to show us the areas of the problem. So if you have a problem in your neck or your shoulders, your doctor's probably going to want to see those areas. So what we can do is have on something that will permit the doctor to see as much as possible. This could be a t-shirt, this could be a tank top, this could be a shirt that's easily movable and lift-upable, so we can see as many areas as possible. But if we have a neck problem or a shoulder problem, we're going to want to see those areas. Make sure you have enough room to move your limbs during the examination. We're going to have you move and not hit things in the ceiling like I just did. But you want to have enough room to move around so the doctor can see the range of motion about your joints. You want to be able to make sure that the doctor can see the areas that are problematic for you. So if it's a neck problem, you want to be able to show them all the areas of the neck that are troublesome to you. If it's a shoulder problem, you want to be able to show them all the areas of the shoulder that might be troublesome to you. Same thing goes for the elbow and for the wrists. If you have a back problem, you want to make sure that you have a shirt that you can pull up so that the doctor can get a view of the low back. And this could be, again, a loose fitting shirt or anything that just lets them get a good view. And that will permit good and easy motion. If you have a problem
in the hips or the legs or in the back, because the nerves in the back go in the legs, the doctors going to want to see a little bit more. So you want to make sure that you have exposure of the joints that the doctor's looking at. And lots of times it's nice to have just bare feet, because sometimes shoes we can't assess as we want to with shoes and socks on. So if you have a hip problem, you're going to want to wear shorts. If you have a knee problem, if you have an ankle problem, we're going to want to see those joints. So make sure you wear something comfortable to enable us to see those. It's nice if you have a table nearby. If some of these maneuvers we may have you do on the floor, so a mat that you can put on the floor so we can have you lie on your back and do some maneuvers, that's helpful as well. If you do have an additional person besides the camera person, sometimes to assist with some of these maneuvers, that's a good thing as well. But overall, you know, we want as much information as possible, and by looking at you and having you do some maneuvers, again, we may have you walk, go up on your toes, go up on your heels, move your joints around. Those all are helpful movements that give us information about what's going on with you. So I hope this was helpful for you, and we look forward to seeing you on your telehealth examination.
So we tried to make it a little fun, but also at the same time convey the information we wanted to the patient about really how we set them up in the room, how we examine them, a lot of things that you don't really think about sometimes. We found this with our early evaluations, that the camera wasn't positioned well, I couldn't see them, they didn't have the right clothes on, there were too many distractions in the room. So we find in the introductory video is one of the most popular things right now for people. And then I'll just take you through. This is this is no sound with this, but this is the shoulder exam. And we start off. This is, again, for the provider as well as the patient, but we tell them where things are: clavicle, acromioclavicular joint, subacromial space. We show them how to do range of motion of the shoulder, and trying to put it in simple terms. Raise your arm above your head from the front and then to the side, looking at forward flexion of the shoulder as well as abduction of the shoulder. So we're trying to put it in simple terms for them. We're looking at external and internal rotation. So we're, instead of having them reach behind their back and all that, we're actually taking them to 90 degrees and looking at external rotation from a plane of 90 degrees, and then internal rotation, trying to put that in simple words for them. We're looking at how to assess the supraspinatus here. So this is self-applied resistance in the plane of the scapula. And this also is going to be, this is a feeling of apprehension. So this is going into external rotation if they feel apprehension. So that's an instability, self-applied apprehension, basically. We're having them comfortable with where things are. So the AC joint, this is SCARF sign for AC, acromioclavicular joint pathology. And this is Hawkins test of impingement. So we're having them self-apply Hawkins, basically, by rotation of the hand. Also, we're doing Neer's test of impingement to try and get a feel for impingement, subacromial space impingement. So that's self-applied Neer's test of impingement. And again, all these are as aids. We'll also describe these in much more detail when we're actually with the patient, but just to get them to have a feel for what to do. This is Speed's test for the biceps tendon, self-applied resistance with the hand in supination. And this is Jurgensen's test, again, self-applied. We're trying to get them to externally rotate and supinate while we're stopping that motion plane. Patients can do this actually pretty well. But again, when we do this, we'll go much slower than these are depicted. But this is to give a general overview of the shoulder in general. This is for assessment of the supraspinatus, so the belly press test. If we see the elbow lag behind, that's a positive test there. We wanted to have some measure of looking at external and internal rotation. So using a firm object like a door frame, this would be external rotation strength testing. Does it hurt with that, or do they feel weak with that? We also test internal rotation and having them come inwards. So again, do they have pain provocation with internal rotation, or do they feel weak with internal rotation? So this is going to be O'Brien's test for the labrum. This is position 1, thumb down. They're self-applying resistance from the opposite side. Now position 2 with the palm up. Self-applied resistance from the other side. So this is assessment of the glenoid labrum with O'Brien's test. We find this one actually works quite well in the virtual environment. So that is the shoulder exam. The hip exam, we'll take you through what we have here. We always say that your personal exam may differ. This is just, again, to give a general feel. This is not, we don't do it at this speed, but this is just give the patient what they may encounter from each of these joints. So if we're going to examine a hip, it's nice to kind of send them this beforehand. But again, basically, as was talked about, the things you can have them do and assess: walking on their toes, so that's S1 nerve root. Walking on their heels is going to be L5 nerve root. We can get a good feel of that at least. And again, we show them how to do it, and hopefully by seeing this, they'll know how much space they need in the exam room. Heel walking for L5. And we tried to modify a lot of these maneuvers. A double leg squat, as was mentioned, a nice test of general strength. We're going to watch do their knees cave in? Do they have any dynamic medial knee valgus when they do the squat? Are they able to perform this maneuver? Single leg squat, again, is a nice one to assess dynamic medial knee valgus. So if they have some proximal greater trochanteric pain, oftentimes we see dynamic medial knee valgus with this move. If there's any component, if we're worried about a stress fracture, we'll have them hop on one leg, see where the pain is from that. We want them to localize their pain, again, with one finger, but we'll point to some common areas that may be involved, the PSIS regions or the greater trochanter. We'll try and do some hip range of motion while lying supine. So we'll look at hip flexion with just a simple knee to chest. So hip flexion. And we'll also be able to assess rotation. So with their hip bent into 90 degrees of flexion, we can have them rotate their foot in and out. So external rotation and internal rotation. And this is in a lying position. We'll also show how to do it in a seated position. So that's external and internal rotation. So if they can't lie down, or if there's a difficulty with lying, we'll try and do this seated. We find that using a towel and looping it around the foot is a nice aid to look at that. So we'll look at external and internal rotation in this way as well. So the towel can aid in the rotation of the lower limb. We're trying to tell them to keep their thigh bone, their knee stable, not to kind of come off the bed with those. A few special maneuvers we modified. So placing your ankle on the opposite knee, basically this is Faber's test. So certainly we can have them perform Faber's test and in a self-performed manner and see if that's provocative for pain and where the pain is if they do this. They can also do this if they can't lie in a sitting position. So have a figure 4 position while sitting. Is that pain provocative? So Stinchfield's test for intra-articular hip pathology. So we have them raise and then apply pressure. So this fulcrums the femoral head against the capsule. So if there's arthritis, this is a sensitive test for arthritis, especially when used in combination with Faber's and with pain with internal rotation. You can also do this in the sitting position if it's not possible to do it in the lying position. We can also try and assess the labrum by doing a modified Fadir test, so flexion, adduction, and just trying to scour the acetabulum with the femoral head. It's a provocative test, see if this specifically produces pain. We can do this, again, either in a lying or a sitting position. So log roll, the patient can self-perform a log roll to see if this is provocative of pain. Okay, we're looking at hip flexion, so we can do a modified Thomas test. If the patient can do this, we could see if their opposite hip, opposite to the side they're pulling to their chest, rises up. That could be tightness of the hip flexor, also could indicate tightness of the rectus femoris. So now we're assessing hamstring flexibility, and we use a towel to assist. So this is popliteal angle. So we get a popliteal angle here using a towel to assist. If they're able, and if they have SI-generated pain, we can do a modified Gainsland's test. And this is having them scooch over if they have ability to lie and just put a shear force across that. Might be a little bit, if they could put their opposite leg up toward their chest, but that might be a little bit difficult for a lot of patients to perform. But this at least gives a fulcrum of stress across the SI joint. We try and follow that with the knee. So again, we try and do these preliminarily so that people know what they're going to be asked to do. They kind of get an idea of the space required. Again, basic, just walking to and from the camera to get an idea of alignment. Is there genu varus? Is there genu valgus? What is their gait mechanics? And again, for the knee, we like to do double and single leg squats. How do they control the limb when they do this? Is there any medial knee valgus? Single knee especially can accentuate that. Single leg squat. We point out some areas to localize the pain. Again, tibial tubercle, patella, fibula, joint lines, pes bursa, and show how to get the lateral caudal ligament in a figure 4 position. If there's patellofemoral pain, we just want them to get comfortable with moving the kneecap. Is there tenderness on palpation of the femoral condyles or the lateral or medial patellar facets? They can do that with the knee extended and relaxed. So we just give them an idea of what those are. Just to bend and straighten their knee. This gives us a good idea just of their range of motion, how much range that they have. If they're in a seated position, we can assess as well. So for quadriceps flexibility, we can have a self-performed Ely test. We can see how close they can get the heel to the buttock. We're trying to assess here, again, and this is self-administered, but we're trying to assess varus and valgus stress. So by applying a distal force, a varus force, and a valgus-directed force, we can assess MCL and LCL. This is Thessaly's test. So we're trying to get a meniscal provocative test that they can perform, and Thessaly's is pretty nicely performed by itself. So in just a little bit of flexion, they do a rotational knee twist, and then with a little more flexion, also a rotational knee twist. And hopefully this will stress the medial and lateral menisci, a variation on Thessaly's test. Hopping on one foot again, this can bring out pain if they have a patellar tendinopathy, any kind of impact injury or overload injury, patellar tendinitis. So that gives you an idea of the knee things that we look at. And moving on down to the ankle, or I'm sorry, this will be the spine exam. So we wanted to cover both the cervical and lumbar spine. And again, we want to, and these can be independent. So you may not be doing all of these at once. So you can take selections from these. So if you're just examining the lumbar spine, of course, you just send them the lumbar spine video. So again, we're assessing gait mechanics. We're assessing S1 and L5 nerve roots by heel and toe walking. Is there any degree of Trendelenburg present that we can observe? At least these can tell us a little bit of that if the room is appropriate and we can see appropriately enough to examine these. But so we tried to make the videos as independent as possible so we don't have to show them everything. We can select. Balance and stability, we look at toe and heel walking. Examination of the low back. We want them to localize their pain, again, reminding them of major structures. So the PSIS, ischial tuberosity, greater trochanters, is there anything in those regions? We want to see how their spine bends. So we'll give an example of spinal flexion and extension and see how much they can do from a sagittal plane. Hopefully their sagittal plane will give us the most accurate information there. And we want them to look at that S1 strength. So if toe walking isn't enough, there may be some subtle S1 weakness. So while if they're near a wall or a stable support object, we'll have them rise up repeatedly on their toes to assess S1 nerve root. We'll again check strength in general fashion by a squat, see how good they are with that. Are there any inward movement? Reflexes, we found that a cell phone is one of the best ways, maybe a cell or a spatula, but everybody has a cell phone, and we can use that if the knee is in the right, if the foot and knee are in the right position, we can use that to assess patellar tendon as well as Achilles tendon. They can use a spatula. They can use the side of their hand as well, so that's certainly reasonable. So a seated straight leg raise, this is a dural traction test, and then we can take that into the slump test. So if there's any dural traction maneuvers that provoke radicular pain, these are some that we can have them self-perform. If there's concern of posterior element involvement, we can have them do a stork test. So we're stressing the posterior elements of the spine. We can also do this if they're lying on their stomach. So by a back extension, we can stress posterior elements in the lumbar spine in this way. We can have them do a seated Fabers or lying Fabers test. Again, hip and back are related, so lumbar spine and hip. So neck, we kind of go through the same thing. We look at neck range of motion in the sagittal plane. So we'll have them go through flexion and extension, just see how far they can go in each of those domains. Asking them what we're telling them what we're gonna have them do. We'll look at rotational planes. We'll look at side bending, the same things we would assess. These are things that you can assess fairly well via virtual examination, and probably be pretty assured that the patient is self-performing them pretty well. We'll look at is there any pattern of compensation or anything else that they're showing us. Just for tricep strength, if they're able to, a triceps dips with a chair is a nice upper body strength test just to see how strong triceps are and just coordinated movement patterns. Again, for reflexes, we use those simple things that might be readily available. So they could use their cell phone, they could use a spatula, they could use the side of their hand. But cell phones are actually, the more of these we do, people like to use their cell phones. They're a nice heft and weight to do it. Now, this is a seat exam for clonus, for upper motor neuron signs. We can have them self-perform a Babinski. This is usually pretty well placed, performed by patients. Making a J is something that they can relate to. And for rapid alternating movements, having open and close their hands as fast as they can. You can also do some patterns on their knees. In the lower extremities, you can have them tap their foot fast as they can, so that can give an idea for rapid alternating movements. Sperling's maneuver for foraminal compression, we'll have them extend and then rotate. So we're narrowing the neural foramen if there's any degree of radiculopathy. Thoracic outlet, a lot of tests are not that sensitive, but Ruse test is one that does have some evidence-based support behind us, and that's something they can easily self-perform. By doing that for a minute, does that reproduce their symptoms of upper extremity paresthesias? And we have pictures to go with these. So we have pictures of all the tests. So we have Neer's, Hawkins test, O'Brien's test, position 1 and 2. So these again can help the examiner performing the exam, as well as the patient performing the exam. So each of these are available for physician use as well. We tried to have good word descriptions as well. So in our document, we're going to try and give you enough description as possible. So again, these were very briefly demonstrated video and picture. In the document, we really take you through how to do these and what position we should have the patient in. So we have a lot more description for how to perform the exam, what position the patient is in, how to get the best information. And again, a lot of these are self-performed maneuvers. So we are, it's left to see how valid these are. We know the validity of our face-to-face maneuvers, say for O'Brien's test for labral tears, how sensitive that is. How sensitive is it when a patient is performing it? That we don't know. but we tried to base our telehealth musculoskeletal exam on validated physical exam maneuvers. So hopefully we'll get information that will be accurate and reliable for us. Again, seated favors, a lot of these are positions that are a bit unique. We use the towel to look at hip internal and external rotation. So important to have them stabilize the lower leg when they do those. So the self-performed maneuvers are the ones that, are novel, but those are the best, I think, if we can give them the most pictorial help we can by pictures and the most video help we can by seeing someone else do it or us doing it ourselves as we're going through the exam. I think that's most helpful for them. So in summary, it's again, telemedicine and telehealth, as all have said, is here to stay, and it's probably going to be a very important part of our practice even after COVID is resolved. And we can get a lot of information out of the musculoskeletal exam. I think initially, again, when this started, I don't think people were using telehealth much for musculoskeletal exam. And I think when this started, people had a lot of questions about really how to do this well and how to get the most information from our patients. But we really can have some strategies that can give us good information. And really we can take and choose these things and modify according to what the patient can do. Again, you can imagine the patients I see are any from elite athletes in professional sports to 80-year-old masters athletes. So there's going to be a broad spectrum, and we can modify what we do with the patient based on their abilities and also based on the comfort level of the examiner. A primary care physician carrying out this exam is going to emphasize much different things and maybe select out some things much different than a physiatrist performing this exam. So in the future, I'm sure this is iteration number 1. So I'm sure we're going to refine and validate patient-performed maneuvers and kind of get this even better. But at least this gives us a guideline to at least have some path forward. I thank you very much. It's been great to hear everybody and great to present this information. I'm happy to answer any questions if anybody has any.